So the next speaker is hard to introduce. She has an incredibly long CV, so I'll summarize as best I can. Dr. Barnes is an extraordinarily accomplished academic investigator. She lists nearly 200 publications. Currently is on about 10, I sort of lost track, about 10 different NIH vehicles, many of which are very large multi-investigator projects, and has mentored a small army of students and fellows through her career. So with respect to all the things that we looked at when we assess academic accomplishments, she's done extremely well. She was a product of Johns Hopkins. She started there as a fellow in '93 and rose up through the ranks to full professor. But very fortunately, last year, we were able to recruit Dr. Barnes to the University of Colorado into a new role that's turned out to be incredibly exciting. So she's both the director of the Colorado Center for Personalized Medicine, as well as the chief of the newly formed division of biomedical informatics and personalized medicine. This is something I'm sure you'll appreciate, touches almost everything that we do. And so it's really great to have you here to talk about it, Kathleen.
Thanks, Craig. Thank you. Let me see, how do I get back to... What a nice introduction. And some of you have probably heard me give the spiel, so this is going to be a major shift from that fantastic presentation we just heard. Let's see, sorry. Wrong side. There we go. Okay, so I'm electronically challenged. This is a major shift from Eric's presentation. I'd love to talk to you about the science we've been doing, but this is a really terrific opportunity to share with you all this initiative that really is an institution-wide initiative, why we're doing it, define what we call personalized medicine. But I really want to spend the 20 minutes to talk to you about what we've been building and I think tremendous research opportunity as a result. So what is personalized medicine? It's sometimes called precision medicine, personalized medicine. People don't feel strong about one versus the other, but in essence, it's this young and rapidly advancing way of thinking about healthcare. And the difference from the more traditional medicine, I suppose, is that it's informed by each person's unique clinical, genetic, genomic, actually multiple omics, I've only listed a few here, combined with environmental information about the person. And the real premise behind personalized medicine is that one size doesn't fit all. So what do we mean by that? Clearly there's a need for more precise treatment from the way we've been doing things. The status quo doesn't always work. The traditional model has been more sick care versus health care, tends to be a guessing game about what's the best way to treat an individual. And that can be illustrated in one of many similar publications, this particular one from a couple years ago. This is looking at the top 10 grossing medications for 10 different conditions in the United States. And for each of these drugs, if you will, used to treat a different condition, so schizophrenia, arthritis, and depression, and so on, for every blue individual for which the drug is effective, there are those red individuals for whom that drug is not effective. And this really surprises a lot of folks, how dramatic this is. And you see really big numbers for example, Nexium and heartburn. How many individuals do not respond well to that drug? And I use that rather loosely, those who are unresponsive, those who respond adversely. So a simplistic way of thinking of personalized medicine is really focus on the pharmacogenomics, and we tend to think of that as the low-hanging fruit, and that's a lot of what I'm going to talk about. Think of it as the right dose for the right drug for the right patient at the right time. And it's illustrated in this schematic where you have a patient population, and some are going to benefit from a conventional treatment, and others are going to be unresponsive or respond adversely. So personalized medicine, then, is this integrating health record information, data from patients, and combining that with omics data. In this particular example, we're talking about genetic information. And we use that then to make predictions about how a patient's going to respond to therapy, and importantly, in the clinical setting, how to make decisions about what that patient should be receiving. So it's really, personalized medicine is shifting this traditional paradigm. What do I mean by that? The previous approach was more descriptive medicine, moving into understanding the mechanism behind the disease. An empirical diagnosis, and this is a big shift, a different way of thinking, an empirical diagnosis versus thinking of mechanism-based diagnosis, combining all of that omics information. Traditionally thinking of grouping diseases by organ as opposed to subgrouping based on a molecular or biological classification. Uniform treatment versus individualized treatment, you've heard a lot about that. Big difference, retrospectively diagnosing a disease versus prospectively evaluating the disease risk and intervening. And shifting away from a sort of an acute care approach to early detection and intervention. That's the power of personalized medicine. So the advantages would seem clear with detection, prediction, and prevention of disease. What do we mean by that? It's development of biomarkers. I think we heard some great examples just now from Eric. That is personalized medicine very clearly. To use biomarkers, identify biomarkers, develop biomarkers to clarify specific patient populations. This has benefit beyond the individual to the larger population, certainly, giving you more earlier, more specific diagnosis, focused on curing, and accurate monitoring of the disease state, and then efficiency. It's a no-brainer that by prescribing the most effective medication, if you can use that example to a patient, you're going to reduce costs, and it's going to be more efficient and effective for the patient overall. So the potential for real reduction in healthcare costs by not using a trial and error approach, and improving the efficiency in terms of treating the patient. So how does personalized medicine work in this framework of pharmacogenetics, which is really what I'm giving you examples about so far? So again, you have this patient population. All patients have the same diagnosis. We have a number of tools at our disposal. One of the ones that we're focusing on here at the Colorado Center for Personalized Medicine is something like a SNP chip, so a single nucleotide polymorphism chip, a chip that's loaded with variants that include clinically actionable variants, depending on what we're interested in, if it's drug gene pairs, heritable traits, and whatnot. So we can genotype a patient population on a chip like this, and from that we can begin to stratify that population into those who are non-responders or worse, toxic responders, and make the decision to treat them with an alternative drug, versus those who are going to respond well to the conventional therapy, and one can proceed forward. And this is already being done at other personalized medicine programs. This is an example of a 250 SNP chip that was developed at Vanderbilt. You can see this is a very inexpensive tool that can be developed. And you can imagine this chip with 250 genotypes, if you will, on the chip that can be easily genotyped on a DNA sample, and it's loaded with known, sort of validated drug gene pairs. So if you have this variant, you're going to be a poor metabolizer to Plavix, and so on. So this technology already exists. There are lots of challenges in getting this technology in the pipeline as a standard of care. But it is a goal. So let me talk a little bit about who we are, what the program is. Again, this is a joint venture across the entire institution. It's multidisciplinary and multifaceted, and I've listed the stakeholders here. A special thanks to David as the chair of the Department of Medicine, which has been a huge stakeholder in the program, and for which the actual division of biomedical informatics and personalized medicine sits. We got some nice press about a year ago in the 5280 magazine on building our program and what that was all about, and a nice schematic that came out of that I'll use to sort of walk you through who we are and what we are. and why I think that's relevant to research such as Eric's and others and an opportunity. So we start with the patient population. All personalized medicine programs start with the patient population. This was a huge draw for me coming here. This is a really unique patient population here. It's a large patient population. If we just look at UC Health and Children's combined, I think the stats have changed, have increased in the last 6 months, but I've traditionally thrown out the number, something on the order of 500,000 new patients per year walking through the doors of UC Health and Children's combined. It's a demographically diverse population. It's a population with a unique opportunity to begin to tease out environmental factors such as urban versus rural living. And then there are significant points of excellence here on this campus that draw these patients, obviously with the Cancer Center and a robust cancer program, high altitude medicine, and so on. So lots of opportunity with the patient population here at UC Health, a big draw. Another huge advantage of our program, and I'll take a step back and say before I came out here, I heard a lot of, wow, there are other programs that are so much farther ahead. Vanderbilt's been around, partners, and so on. We've got to play catch up. And that's true when you're building a new program, but there's 2 points to that. One, you can learn from others' mistakes and decide what's the best way to model our program to be most successful most quickly. The other is some of the advantages I just mentioned, in addition to in the electronic medical record area, there was already the development of the data warehouse, health data warehouse called Compass, which I imagine most of you are familiar with. So that was established before the center was actually established. And consequently, there's something on the order of 7 or 8 million unique records in Compass. So when these patients come into our program, we have this rich longitudinal data to leverage. So another big advantage. So that's the data warehouse, and Compass is, in effect, an operational unit that's part of the program. So you can imagine right off the bat we're talking about a lot of data. And I like to show this slide to underscore really one of the challenges in, I would argue, genetic epidemiology and where we are in the field of research has been the bottleneck of big data. You hear a lot about big data, but just how big is it? So folks ask all the time, how big is the human genome? The analogy is often used that if you sequence your genome, it takes up about as much space as a desktop PC. So you're talking about a lot of data. You can imagine when we pull together this rich EHR data and combine that with omics data, such as genetics data, let's just stay on that for a second, sequencing of the human genome. Eric Dishman, the new director of the Precision Medicine Initiative at the NIH, stated recently, if you sequence genes of the 1.65 million Americans who are going to be diagnosed with cancer just this year, you do that just once, and then you add the clinical and add on to that imaging data, you end up with 4 exabytes of data. Most folks think in terms of megabytes and gigabytes, maybe getting into terabytes and petabytes. An exabyte is the next step up. And that's equivalent to all of the data that's in the Library of Congress. So we're talking about a massive amount of data. What do we do with all these data? Well, a major focus in developing the program has been in anticipation of this kind of big data, having the infrastructure in place to handle those data. And I won't spend a lot of time to say too much about this. This is a wonderful image from Zhu Fang to really illustrate all the different types of data flowing into our program, into the biobank, which I'll mention, other sources of data, and then stopping here. So TICR stands for Translational Informatics and Computational Resource. It is an operational unit we've built within the center. We just launched an HPC that's open to the faculty on this campus, and we really encourage folks to find out more about that. But that provides us the infrastructure to handle the computing, networking, and ultimately the storage of all the data that we anticipate from the program. So the other piece of this, and I really want to call out on this one, is development of the biobank and what we're doing with samples once they come into the biobank, because that, I believe, is the real research opportunity, hopefully, for all of you. So when we talk about the biobank, initially, we conceptualized the biobank as a place where all of the biospecimens from these patients would come in and provide that research opportunity. But we have the dual opportunity of also making this a clinical biobank, if you will, so that ultimately, when we make our discoveries, we can legitimately take that information back to the participants or the patients. So what we're doing right now, we have a consent form that's been up and running now for several months, and we launched it UC Health-wide back in October. There are lots of things about this. We want to change the process over time to capture more folks. If you look at the Vanderbilt program, which I'll remind everybody had been in place for well over a decade, they have a success rate on the order of 85% of the folks who are asked participate in their biobank. That's both adults and children. Right now, we're somewhere around 30 to 40%. But what I'll say about that is that we're growing, we're developing. There's lots of marketing we need to do, and there's lots we need to do in terms of improving the way that we're reaching out to folks. Right now, you come into a clinic at UC Health, you're handed a form, asked to read over it. If you want to participate, you sign. So self-consent, we can do better, and we're working on that in the clinical operations space. If you agree to participate in the program, a blood sample is taken either at that visit, if you have an order for a blood draw, or when you come back. And then that moves into the biobank. We're finalizing the biobank at this point. It's over in Biosciences 2. It's a state-of-the-art facility with automated DNA extraction, high-throughput genotyping, and so on. We're in the final stages of getting ourselves CLIA registered so that we can continue with this process. So right now we're just banking all of the samples. We have over 10,000, 11,000 so far. DNA will be extracted. And then we will generate genetic data immediately off those samples. So that's something a little different we're doing from some of the other programs that are just stockpiling DNA samples until a researcher, Eric, comes along and says, you know, I want to look into genetic associations with X, Y, and Z. We're generating data as the samples come through the door to build this database that you could immediately interrogate to address your research questions. That moves into the research space, into the clinical space. That would fall in the domain of return of results. That's a complicated pipeline to develop. We have a PharmGX committee that formed last summer. It's an incredibly active committee. And we've already made great strides in working out that pipeline, what that will look like once we generate, for example, drug gene pair data off of the SNP chip that we're using and putting that into the database, developing out that pipeline for a physician's order. We'll have to go through a secondary consent process. That is, we'll say to you, you gave your blood to be part of this program. We have the potential of returning results. Do you want them? So we're working out the logistics of that with the ethics folks. And working with the EPIC engineers to figure out how to get this back into the clinical space in that area that we call clinical decision support. So bringing research to the clinical space, what do I mean by this? Making research available to all. So this belongs to all of you. It's an opportunity for all. Learning more about what impacts health and disease. What does that mean? Your particular area of research could have a great impact in developing new discoveries and developing new therapeutics, new targets, and whatnot. It's important to keep this circular. So if someone comes in and participates in the program, we want to be able to give back to the participants and keep them engaged long term. Where are we so far? We have over 30,000 patients who have signed the consent form as of the last couple weeks. This is just at UC Health for now. Our intent is to partner with children. There are lots of additional ethical issues, including children in a study like this, but we're working on that with our children's partners. We have over 10,000 blood samples, as I mentioned, in the freezers waiting to move forward, and we anticipate that sometime in April. And what's really, really critical in this area of research and clinical delivery is the more folks who participate, the more data that we have, the more we can discover. I mentioned clinical decision support. What do we mean by that? So if we just stay with the notion of drug gene pair information derived from this genotyping chip, working with, as I mentioned, the EPIC folks and the EPIC engineers to get that information back into the EHR. You could envision that we are selecting a subset of validated drug gene pairs to work with, getting that information into EPIC so that at the time of the provider encounter, if the provider says, I need to prescribe warfarin to you, if this information is in the system, he or she could immediately make a decision about whether that is the right drug or not, or dose, based on the information that's in the system. Ultimately, down the road, what we want to be able to deliver is information back to participants/patients more than just drug gene pair information, what therapeutic and what dosing you should have, but heritable traits that would be relevant for patients. That's a more challenging process to develop. We are working on that, and we have the capacity to deliver this kind of information from the genotyping chip that we're using. But this, as you can imagine, involves genetic counselors on board, physicians to truly be on board with the process. The other kind of fun thing that we're working on in the center to be able to give back to participants sooner rather than later is ancestry data. I'm always surprised when I give presentations to the public, folks are almost more passionate about their ancestry than they are if they carry a BRCA1 mutation and so on. And to be honest, direct-to-consumer organizations like Ancestry.com, 23andMe, they are really pushing this field forward for us because they're sensitizing to the public to the value of genetic testing. And so folks are really excited about this. This is non-clinical information. We use ancestry information both in research as well as developing out those drug gene pair pipelines, because it's important to know ancestry because the frequency of variants for these different SNPs, if you will, vary according to ancestry. But it's non-clinical information, and it's the kind of information that we hope to deliver back to folks. So I'll just close with, in defining who we are, we're really building from the ground up, which is truly exciting. This is the infrastructure we've built so far. We have our space over in Building 500 for the moment on the 5th floor, so I'd love for you to come and see us and see what we've begun to put together. We have a truly fantastic infrastructure in terms of the administrative and support staff that we've built. The division is growing by leaps and bounds. There were a couple in place when I got here. We're at 13 primary faculty now with 10 secondary faculty who are as engaged as the primary, which is fantastic, and we have several recruits in the pipeline. I mentioned Health Data Compass. I mentioned Ticker. I've talked about the biobank. The other really key piece down the road for the once we make the discoveries in terms of developing new tools is partnering with the molecular diagnostics folks. And so Dara Eisner and Christy Crooks have been integral in building out our program and ultimately developing new tools. Matt Taylor leads the clinical operations arm, and that is another area of rapid growth as we figure out how to reach out more, not just at UC Health and include children's, but begin to reach across the Front Range. So with that, I know there are only a few minutes, but I'm happy to take any questions about the program. Thanks for your attention.
Discoveries are made. Discovery that's made.
Yeah, no, that's a terrific question, David. So, I think the first answer is validation, replication and validation, and which are similar principles in the research space. In terms of translating that into a clinically approved product, if you will. So, there's some proof of concept of this already, partnering with the Komoko folks. So, variants for traits, for example, Huntington's are known. Christy Crooks has just recently developed an in-house test for Huntington's, so that's a fairly easy thing to get out there in the space and leverage. The more complicated would be with the drug gene pairs, and that, again, is where validation is critical. And that's where I think where the bottleneck or where we haven't done as well probably has a lot to do with partnerships. So one, partnering with other biobanks, that's a tremendous opportunity for replication and validation. And when I talk about, validation, of course, comes in all shapes and sizes. One of the things that's important to us is a discovery made in the development of a new therapeutic or target and so on. How applicable is that across the larger population? Is it unique to a particular race, ethnic group, gender, and so on? So by partnering with other biobanks, we have the opportunity to test that. The other partnerships that we recognize that are critical, and we're already beginning to have these conversations, are partnering with big pharma. And I think that's going to be a critical next step. Designing clinical trials that are specifically tailored in a personalized medicine space. That's our vision for the moment. Getting folks on board with, for example, with the drug gene pair or pharmacogenomics space, there's CPIC. It's a national organization, and it vets this information. And as an organization makes a decision, yes, this you can move forward with. It's valid. There's a backlog of that, and that's just one example of personalized medicine. Oh, yeah. Absolutely. I would argue we're doing that. We're one of the very few personalized medicine programs that's using a standardized biobank chip on everyone, and we've enriched that chip for valid information as of now. It's iterative, so it'll change over time. Vanderbilt partners, even UF to a certain extent, are still piloting these diagnostic drug gene pair chips. We're planning to launch that.
I think that's great. The mega chip is fantastic.
But it's not the only way.
What I was talking about, we're seeing.
Yes.
Why can't I? It's really valuable.
Right.
In terms of.
Right. I think validating that content, that information across other biobanks is going to be absolutely critical to move into that space. Terrific question. So some of you may have heard, I think it was about 2 months ago or so, there was a story on Morning Edition on NPR of one of the first places that is trying to roll out whole genome sequencing in newborns. This was at Harvard. There was lots of discussion around that. And it immediately segues into the ethical, legal, social issues, or ELSI, around genetic testing. The issue being, who makes the decision of what's done with that information once it's generated, because the newborn, the child, can't speak for him or herself. So if you sign up for Understand Your Genome, you have to make a decision how much information or what kind of information do you want back. I did it myself. I wanted everything, but I didn't want to know about an inactionable neurodegenerative disease. A child can't speak for him or herself on whether that information ends up in his or her medical record for life. So it's a fantastic question. If you ask me to dream where are we going to be 10 years from now, one can imagine. It's hard to imagine that we wouldn't be in that space where that's happening. But there's so many ethical issues that have to be sorted out before we move there. Thanks, everybody.
Well, your passion